This is LiveWell Talk on thyroid cancer. I'm Dr. Dustin Arnold, Chief Medical Officer at Unity Point Health, St. Luke, Cedar Rapids. While many of us are planning to celebrate National Square Dancing Month in September, it is also Thyroid Cancer Awareness Month. And joining me today is Dr. Michael Telisak from Physicians Clinic Iowa, Ear, Nose, and Throat to discuss risk factors, signs, symptoms, and more. Dr. Telisak, welcome to the podcast.
Thank you, Dr. Arnold. Appreciate the visit and hope to let people know a little bit more about thyroid cancer.
Well, to start off, what's the thyroid do? Why should people care about their thyroid?
The thyroid is a endocrine gland, so it's a gland that releases hormones, and its main purpose is to help regulate our metabolism.
Okay, so if the thyroid's overactive, metabolism increases. If it's underactive, then the metabolism is not where it needs to be.
That is correct.
And obviously, any gland or structure in the human body can develop cancer. I mean, the heart, it's really rare, but there is such thing as heart sarcomas of the heart. But tell us about the risk for thyroid cancer.
So thyroid cancer risk, well, I'll give you some numbers. Average per year is about like 45,000 people are diagnosed with thyroid cancer a year. So fairly common. And it's one of these cancers that's discovered more and more over the last 20 years or so. And it's a combination of maybe some influences, environmental influences we don't fully understand, and then also increased imaging. So ultrasounds or other imaging performed for other reasons. Now that we have availability of this in our healthcare system, more and more we find nodules that otherwise would go undiagnosed or underappreciated.
Do patients how do I say it? Do they present with certain symptoms? Can you feel that you have thyroid cancer, or is it something that's found on exam
Most
or?
most cases not. Late stage thyroid cancer where it's spread to different parts of the body, you might feel as bumps in your neck, that kind of thing, or other symptoms. But otherwise, generally, no, it's actually found as a nodule. Although sometimes when the nodule is larger and grows over a period of time, a patient can feel a lump in the throat or notice a lump in the throat and they look at the front of their neck.
Okay. Um, is there screening for thyroid cancer? Like we've had physicians discuss breast and colon malignancies, and what is recommended for screening to detect it early. What is the screening for thyroid cancer?
Thyroid cancer doesn't really have a defined
Okay.
screening. The main thing would be is, as every patient should, have a routine physical exam with their primary care doctor, and part of that exam includes a neck exam where they may feel a palpable abnormality, and then there's patients that are more at risk that need to have more routine examinations or evaluation, sometimes with imaging or lab tests.
You don't see it very often now, but in older patients, they would have a goiter that they would just leave. They just,
Mhm.
went about their way. Is that a risk for that to turn into cancer over time?
Good question, Dr. Arnold. So, goiters are less and less common in the United States. There's endemic goiter and non-endemic or multinodular goiter. And endemic goiters, when there's an iodine deficiency in your diet, we see less and less of that in Western societies. That still occurs in other parts of the world because we have iodized salt, and that's beneficial in that regard. And actually, a low iodine in your diet is a small predisposing factor to thyroid cancer, although a low risk in general. So we don't see that as much, but yes, people can typically have a goiter nowadays. It's typically multiple nodules, and those tend to be less concerning for malignancy. Although still, if somebody has a larger nodule in those goiters, we still want to rule those out as a possible malignancy.
Okay. And you do that with ultrasound and then subsequent biopsy?
Ultrasound, subsequent biopsy, that's correct.
Okay. Now, after the biopsy comes back and it is cancer, I'm sure there's different types of cancer. In fact, I know that there are different types of thyroid cancer, but what are the ones that are worrisome, and what are the ones that are relatively easy to deal with?
Good question. So, by far the most common kind of thyroid cancer is papillary thyroid cancer, and that's 85-90% of all cases of thyroid cancer. Okay. So, when people are diagnosed, this is typically their diagnosis. Now, the good news with papillary, then there's also follicular cancer. These tend to be well differentiated. In other words, the cell types are very similar to the thyroid cancer, the thyroid cells that they came from. So, they respond well to treatment and tend to be less aggressive. And then there's other less common forms of cancer, medullary thyroid cancers from a certain cell from the thyroid, and tends to be more higher chance of it being a genetic cause, with a family history or with a some endocrine related genetic reasons. People are more prone to these, but some of them occur, and they are like 3% of thyroid cancers. And then anaplastic thyroid.
We all know that from watching television and the commercials for Ozempic, that
Yeah,
if you've
yeah.
had a family history of medullary thyroid cancer, the if you die, it's not our fault statement during the commercial, but they do always say that.
Yes, that's true. True. So I mean, but that's generally what. But so those are much less common. Of course, anaplastic thyroid cancer is probably the least common, and that tends to occur in patients over age 55 to 60. It's again pretty rare, and it's very aggressive. Typically, when it's diagnosed, it's already spread and spread locally, especially, and difficult to treat.
Wow. So, what are the treatment options?
Good question. The primary treatment option for thyroid cancer, the first treatment option is surgery. So either removal of part or all of the thyroid is typically recommended. Other cancers, if they're smaller in size, there's some newer kind of variations of which aren't really initially were called cancers that really aren't cancers at this point. That we typically can monitor actually just with imaging and repeat testing. So that's the good news about that, is less aggressive treatment with still the same long-term survival rate, very high survival rate with these kinds of changes. But overall, it's generally surgery. And then depending on the extent of the cancer, the patient's risk factors, and the nature of the final, evaluation of the pathology dictates if they get additional treatment, such as radioiodine therapy, or sometimes external beam therapy, or even, as you're discussing, some kind of different therapies, monoclonal antibody therapy or chemotherapy.
Okay. And so, if you take out my thyroid, I can live without it?
Well, not exactly. You need the thyroid,
Okay.
but the good news is that thyroid hormone supplementation actually is readily available. It works very well, fairly easy to titrate or to manage and change depending on the patient's needs. And ultimately, even when patients have thyroid cancer, we remove their thyroid. Part of the treatment regimen is actually taking thyroid hormone, as it helps suppress growth of the thyroid cancer, any
Oh,
microscopic
okay.
potential
Yeah.
there.
Uh, for our listeners, I mean, the most common, a lot of Northern European descent, obviously, Scandinavian, Norwegian in Iowa, and a lot of people have autoimmune thyroiditis or
Mhm.
hypothyroidism. Is there any risk of that turning into cancer? Is that a risk factor?
Good question. In general, autoimmune disorder, Graves' disease, or Hashimoto's thyroiditis, anything that causes inflammation in the cancer, there's a small risk, but overall that risk is quite low relative to other risk factors like radiation to the neck, which, the amount of radiation that would include would be prior to like the mid 50s, when radiation was used to treat tonsillitis or acne. So that's in a smaller population now, or other risk factors like family history of thyroid cancer.
Okay. Now, we have talked on this program multiple times about the NASA Community Cancer Center located over in your neck of the woods there at the medical mall. Um, how do they provide service for thyroid cancers if a patient should have that?
Absolutely. So when we treat thyroid cancer, like we do for all cancers of the head and neck, we use a multidisciplinary approach. And that includes me, the surgeon, the head and neck surgeon, and the endocrinologist with Unity Point Health, and with the Helen Nassif Center. We use techniques from the radiation oncologist for management of radioiodine therapy and chemotherapy with hematologist oncologist. So it's a combined team approach, and we even have a cancer care coordinator nurse that helps coordinate visits and management and long-term follow-up and care. So it is a really all doctors contributing and participating for the best management of the patient.
Okay. And is there, if you could tell people one thing to avoid to prevent or lower their risk for thyroid cancer, what would that be?
Good question. Generally, for risk of thyroid cancer, and probably just keeping track of things like healthy diet with with the iodine. That, as you may be aware, Himalayan salts and other kinds of salts in the diet, just making sure, or certain forms of diet, vegan diets, things like that, where people sometimes don't get the right nutrition, and just being careful to making sure you're getting the right amount of iodine. And then really for overall risk, just regular visits with your doctor for most patients, unless you have a known family history of thyroid cancer. And we talked about medullary thyroid specifically, and having being vigilant of that and having good follow-up with your doctor.
Okay. Well, one final question. Why did you choose ENT?
That's a great question.
And ENT does not stand for easy nights in tennis.
Yeah, or early nights in tennis, as my anesthesia friends say. But no, correct. As you know well, we handle airway emergencies and all these things too, which can be pretty urgent. So I really, when I started, I grew up in rural Wisconsin, and first doctor really in my family, a lot of farmers in my family. So I grew up thinking I was going to do rural healthcare, but I fell in love with the head and neck. It's a very complex part of the body, very interesting part of the body. And within ENT, we can provide people with medical treatment, which I think is a huge part of it, and surgical treatment. So you can really treat the whole patient, and not just, well, you have a surgical issue, I send you to somebody else, or if you have a medical issue, I don't manage that. It's the whole patient you're treating, including from little kids that have issues to patients that have head and neck cancer, like thyroid cancer, to elderly patients that have balance disorder and other things of that nature.
Well, that's cool. You do a good job, Mike. You really do. Dr. Telisak, thank you for joining me today. This has been great information. Once again, this is Dr. Michael Telisak with PCI, ear, nose, and throat. For more information regarding services, either PCI, which is 319-399-2022, or cancer patients may call 319-558-4876 or visit communitycancercenter.org. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe, and if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.